Usefulness of renal biopsy. By far, the commonest indications of renal biopsy in pediatric nephrology is the nephrotic syndrome. The atypical cases of the steroid-sensitive nephrotic syndrome with hypertension, hematuria, persistent hypocomplementemia, renal failure, azotemia, impaired renal function, aka CKD-like presentations, unfavorable age, not suggestive of nephrotic syndrome, less than 2 years, more than 15 years, someone says 12 years, 10 years or something. So, nephrotic syndrome with the vasculitic or systemic presentations, lupus and other suggestive, there should be biopsied. And then your resistant cases, steroid resistant cases, 70 to 90% non-genetic, there should be biopsy. Genetic cases, there should not be biopsy because 10 to 30% of the resistant are monogenic. There should not be biopsied because the genetics reveal all the diagnosis. CNS cases, congenital nephrotic syndrome, 60% to 85% cases are genetic. That need not to be biopsied. That doesn't give much information. Then lupus nephritis, there should be biopsied in the first attack, in the flare, in between when you give CNI, and because the treatment is stage wise, and biopsy is a must. CNI cases, there should be biopsied. And then even your infantile cases, 50% of genetic, infantile nephrotic syndrome, 50% of genetic, and rest 50% are not. So there should be biopsied. C3GP is diagnosed when someone is having APA-like presentation, not resolving by 3 months or so. You have now C3GP. So they have APG and not resolving at the same time, persistent proteinuria more than 1 month or so, 14 days more, obviously, gross hematuria more than 1 month, and nephrotic presentation, renal impairment, that should be biopsied. So their differential diagnosis may be C3GP. C3GP, two types. The C3GN type 1, 75%, DDD, dense deposit disease, 25%. They are diagnosed by they are histological diagnosis basically, and electron microscopy is needed to identify dense deposit disease. So apart from that, the Alport syndrome, you have lamellation, thickening, thinning, spitting. They are diagnosed by the histology, help in your electron microscopy and other adjunct measures. So biopsy also tells you the interstitial fibrosis, tubular atrophy, crescent formation. So there should be biopsied, and then your IgA vasculitis, IgA nephropathy, the deposition of IgA in systemic disease like previous henoxalurin purpura, now called IgA vasculitis, should be biopsied. IgA nephropathy should be biopsied. So almost ANCA vasculitis. So good amount of GN. And then transplant patients, post-transplant acute and chronic rejections, and a few more entities need renal biopsy. So biopsy also decides the next course of action, drug toxicity. So biopsy is a safe procedure in good center and good hand. Only 0.01% nephron renal loss throughout the globe, but in good hand, good center it is virtually zero. Patient loss nowadays almost zero, but should be done in a well-equipped center, and the coagulation profile should be seen beforehand. Also, the platelet count, CBC must be seen, hemoglobin, total count, platelet, they must be normal, and the PTA, PTT, your fibrinogen, that should be ideally checked, and the good hand ultrasound guided biopsy is essential within the safe place, safe hand, and gives plenty of information. So now there's no major complications like ABV, fistula, infection, hematoma. They are nowadays not that common nowadays.